Hi everyone, we're going to talk about cardiovascular disease. This is chapter 48 in Darby and Walsh 5th edition. These are the objectives for this unit. Patients with cardiovascular disease are considered patients with special needs. They may or may not require us to alter our normal care, but we have to be educated about their conditions and how our treatment could be affected. These are the types of cardiovascular disease that we're going to go over in this chapter: hypertension, coronary heart disease, dysrhythmias and arrhythmias, congestive heart failure, congenital heart disease, valvular heart defects, rheumatic heart disease, which is a manifestation, the cardiac manifestation of rheumatic fever, and infective endocarditis. So alterations of the heart and or blood vessels that impairs function is the definition of cardiovascular disease. So it can manifest itself in several different ways. It's the leading cause of death worldwide and in the United States. It's 45% of deaths worldwide though. Management of risk factors is really the most important thing. Having patients understand their risks and the modifiable risk factors and non-modifiable risk factors. Cardiovascular disease and periodontal disease share common risk factors, which are diabetes, smoking, age, and poor socioeconomic conditions. And we know that chronic infection from periodontal disease may increase the risk of cardiovascular disease. So research suggests that the systemic inflammatory or immune response to periodontal infection could possibly increase cardiovascular risk, but we know that we are not saying one causes the other. We know that more research is needed and that modifying risk factors certainly decrease the prevalence in the population. So we know there's a correlation, there's a relationship there, but we're not saying that science hasn't said one causes the other or one has a causative effect, but they're definitely intertwined. Let's see, so when we talk about risk factors, we're talking about modifiable and non-modifiable. When we look at non-modifiable, we're looking at our genetics, our age, our race, and gender. There's another category that they call disease patterns, and that's things like a history of eating disorders, bulimia and anorexia, could have resulted in some damage to the heart, and then taking medications such as fen-phen can also have done some valvular damage. Modifiable risk factors include personality traits, your high stress, people that are just perfectionists, type A, go, have to just work their little tails off, professional stress in your job, oral contraception use, if you take an oral contraceptive, tobacco use, a sedentary lifestyle, people who just don't move a lot for their work or in life, they just do a lot of sitting. Diet, of course, is huge. Hypertension and control of hypertension, obesity, diabetes, and periodontal disease. Risks for heart disease can be, I already said that. Okay, there we go. Okay, so the first one is hypertensive cardiovascular disease, or hypertension, or high blood pressure, as we say it most often. And so what is it? It's a persistent elevation of the systolic and diastolic blood pressures. And hypertension is not considered a disease, even though up here it says hypertensive cardiovascular disease, but it's actually considered more of a physical finding or a symptom. So usually it's in combination with something else, there's usually some kind of a causative effect. Either it's in conjunction with another disease process, or it possibly is a lifestyle related, but oftentimes it's a physical finding caused by something. Sometimes they're not sure what is causing it, and that can actually be very often. Individuals with systolic and diastolic blood pressure readings in different categories should be designated to the higher category. So when we look at the blood pressure categories, if somebody is falling in the 120 to 129 range, but the 80 to 89 range in the diastolic, then we're going to default them to hypertension stage 1. So they're always going to default to the higher category. Nearly half of people with high blood pressure do not have it under control. Many individuals with diagnosed hypertension are not treated or are treated inadequately, leaving the condition uncontrolled and the person at risk for other serious diseases. So the worst thing about hypertension is not so much having it, because you can have hypertension for many years, not really feel any negative effects from it, but it's the cumulative stress on the body. It's very difficult on the body to have a constant state of high pressure. I mean, you think about a hose or something, some kind of an object that's constantly having pressure put on its walls. It's difficult to hold and sustain that, and so it's hard on your body. It's hard on your small blood vessels, your eyes, your organs, to constantly have the stress of the high pressure. So hypertension risk factors. Family history, of course, is a risk factor. Race, stress, of course, is another more obvious one. Obesity, diet, so high dietary fat, saturated fats, and sodium. Sometimes someone just lowering their sodium intake can lower their blood pressure. Sometimes it can be very simple. Tobacco use. Again, oral contraceptives, a fast-paced lifestyle that kind of goes with stress, and then being over 40 kind of notches you up to another risk factor as well. So hypertension can be kind of divided into two categories: primary and secondary. Primary hypertension, there's not really specifically a known cause. It's the most common type. It's characterized by a kind of a gradual onset or an abrupt onset of short duration. Secondary results from an existing disease or another cardiovascular disease, renal disease, an adrenal gland disease, or neurologic system disease. So it's usually in conjunction with something else happening in the body. Early clinical signs and symptoms are occipital headaches, vision changes, ringing in the ears, dizziness, weakness in the hands and feet. So because hypertension usually follows a chronic course, patients with this condition may be asymptomatic. So like I said, it doesn't always really bother people, or their healthcare provider says, you have high blood pressure. And they're like, yeah, okay, I'm not bothered by it, so I'm not worried about it. So it's important that they're educated on the dangers of sustaining high blood pressure. As the condition persists, advanced signs and symptoms can increase, including hemorrhages, enlargement of the left ventricle, congestive heart failure, angina pectoris, and renal failure. The dental hygienist refers to patients for medical diagnosis if a hypertensive disorder is suspected. So it's our job to screen patients and then refer them to their doctor. Hypertensive cardiovascular disease prevention and treatment. So we screen, we monitor, and we understand our risks. So we can educate our patients. Diagnosis of underlying medical conditions. Sometimes we help patients realize something that's happening in their body because of our screening and our monitoring and our education. We also need to be aware of the drug therapies that patients may use and the oral system implications. So diuretics, that promotes renal excretion of water and sodium ions. Sympathetic, I think I said that wrong. Sympatholytic agents, they modify the sympathetic nerve activity, and then vasodilators, they increase the vessel size and they facilitate blood flow through the vessels. Hypertensive cardiovascular disease and your dental hygiene care appointment. So drug therapy may cause things like fatigue. It can cause patients to be lightheaded and feel dizzy, or a nausea. It can cause xerostomia. That's a big one for us to think about. Orthostatic hypotension, being very careful when you raise your patient up out of the chair, not to have them stand up too quickly. And then GI disturbances. Uncontrolled high blood pressure. Patients need to not be treated. We have our cutoffs in our clinic. We have to postpone treatment till their high blood pressure is under control. We want to reduce their office stress, the stress and anxiety they have when they're in our office. So talking to them about stress management and figuring out what we can do to make their appointment more comfortable. And when it comes to local anesthetic, we want to be careful with our epi. We want to may choose a local anesthetic without epinephrine, maybe the 3% mepivacaine. And then if we're not sure if it's something we need to worry about or not, we can always consult with their physician. Here's a reminder of our protocols. Our cutoff is 160/100 for systolic and diastolic. And what we would do is with this one here for our cutoff, we would usually walk our patient around, give them a drink of water, take their blood pressure again, have them sit, with their feet flat on the floor in a chair, in a regular chair, not just the dental chair. Inform the patient of their condition. We may want to refer them to their medical provider, and then we'll need to get. Usually we'd like to have a clearance before they come back so we don't waste their time. If they're just going to come back and have high blood pressure again, we would really like to see that it's been taken care of. And then a hypertensive crisis is if they're over 180/120. And in that instance, oftentimes they should go see their physician straight away because they really should potentially get on some medication because that's extremely high. 180, I'm afraid you're going to actually see that quite often. I tend to be, and I'm not a doctor, so, take this with a grain of salt, but what I've also heard other practitioners say is it's really the diastolic that is really sometimes the one that is more concerning. Of course, that's within reason, but I have seen many patients with systolic of about 180 and seen them sustaining that. But really, it's that diastolic one that's over 100 that you really start to get concerned with, because the diastolic is what level your blood vessels can relax to. And so this really indicates a very low level of a patient's ability for their vessels to relax. So they're sustaining a very high pressure. Systolic is kind of your upper level. So there's a lot of pressure up here, but then there's never any release. You see what I'm saying? So oftentimes I kind of get a little bit more concerned about an elevated diastolic. Okay, so I'm going to stop there and then we'll do coronary in the next video.